a guy in cardiovascular medicine, we'll leave it at that, kept interrupting. And there was several doctors in the front. I don't know if he had a lot to drink or what, but he was rude. And I said, look, you're taking up the air in the room, and these guys haven't made their mind up if this is important to them or not. But why don't you give them a chance to listen? And he kept persisting. So finally I said, what are your outcomes like? He had no outcomes data. I said, well,
today I'm excited to welcome Steven D. McConnell. He has his BS, his Master's in Science, CCP, his CIS, and he's a Chief Science Officer to discuss reversing kidney disease. Is it possible? Steven completed his biology degree in just 3 years. He also gained hands-on clinical experience at UPMC-Hamot and the Eastern Heart Institute. He's also led innovative work in both the medical and corporate sectors. His expertise in lipid therapeutics and data analysis has driven successful partnerships and improved patient outcomes. You can learn more about his work at www.healthdefender.com. Please join me now in welcoming Steven McConnell.
Basically, I got into medicine in early '89. I started my education, got a BS biology pre-med curriculum. I went on to a cardiovascular program where I rotated almost exclusively at Columbia Presbyterian in Manhattan. And for a number of reasons, I got out of that field because I thought we could be doing a better job than giving people stents and open heart surgery. Leap ahead a few years. I worked in industry mainly to support my family, but that wasn't really fulfilling me spiritually.
Okay.
So I met some people who were clearly doing a better job than 99% of us, and they were using a lot of niacin. One of them's probably the most famous guy in cardiovascular, William Castelli, who was the director of the Framingham study. Most providers, clinicians know that, and a few other people. And they showed me the ropes. And thankfully, I had a couple of physicians who were close friends of mine. They decided to set up lipid clinics in their practice to keep people from having those procedures. Because the myth is that a stent cures heart disease, and couldn't be further from the truth. And although it opens up the artery and creates blood flow, it doesn't solve the problem that got them there. So I thought there's got to be a better way, and these people clearly knew how. Unfortunately, most of the people that mentored me, and they did it gratis, just for whatever reason, they took me under their wing, and most of them are retired or had passed away. So we set up the clinics, and I decided, based on what I'd learned, that we weren't doing a very good job with conventional testing. And that really hasn't changed much, because this is back in 2003 when the clinics were first being discussed. So I found an inexpensive but advanced set of lab work called the VAP test, VAP. Anyway, Atherotech made it. And it really was just another cholesterol test, but it was a really good one. They didn't measure the particles, but they fractionated the cholesterol that was in the particles.
Right.
It's all about the particles.
Right.
So it was way better than almost everything going on at that point. And if the patient got a bill, it was modest. So very quickly, we saw all the angina disappear and never came back. That was a shock. The admission rate for chest pain, cardiac, acute cardiac syndrome, heart attack, went from roughly 3 per month between both practices. I think it was 5,000 patients, to 0, and stayed that way for 4.5 years. Well, we knew that we were onto something, but it was sort of an act of God that I met someone who was the director of informatics and statistics at Blue Cross Blue Shield in Pittsburgh. And they were known as Highmark. He's no longer there, he's retired, but there was always skepticism, still is. Most people don't readily accept what it is that I do or what I've been able to do. And he very quickly started to realize this wasn't, smoke and mirrors. It was solid. And now he's a very close friend of mine. We had probably the lowest code use in the state, and certainly hospitalization and so forth. That was all the cardiac stuff.
Mm-hmm.
Then my dad comes in. He was in his early 80s. And I just begun to learn this when I tested him.
Mm-hmm.
And, a month later, he had a heart attack, an MI, as they call it.
Mm-hmm.
And he had 3 stents the next day. Within a year, he was in Florida with my mother for the winter and had open heart bypass, and that's where I used to work. He had a quintuple bypass with an aortic annuloplasty. They repaired his aortic valve. And I was devastated. The whole family was devastated. And it was because of insulin resistance, which we do a better job today, but not that great of a job. Back then, we hardly even could recognize it just glancing at the lab work.
Right.
There are a lot of assumptions based on metabolic syndrome criteria, but that's not very specific.
Mm-hmm.
So here's a dad in his early 80s who jumps rope 30 minutes twice a day and looked pretty good. And his cardiac function appeared to be good, but he had a heart attack. Then he needed open heart with a valve repair. We stabilized him. His ejection fraction was less than 25, or excuse me, less than 30, but it was low.
Mm-hmm.
And just niacin, high dose omega-3s, fish oil.
Yeah.
We got him back into the upper 50s for his ejection fraction.
Wow.
That alone was sort of a miracle. But unfortunately, within a year of open heart, I think it was 18 months, he was back for the summer, and he came to the clinic, and the doctor there informed me my father was in renal failure. He had renal insufficiency.
Mm-hmm.
And this is a great doctor, right?
Mm-hmm.
Very, I don't want to say superior, superb attitude. Mm-hmm. That's why he did all this stuff and asked me to help. Mm-hmm. There's no money exchanging hands. Mm-hmm. Insurance doesn't pay for prevention, so we just did it on our own time. Mm-hmm. And I said, well, what stage is he? He didn't know. And it turns out they still don't stage doctors. Mm-hmm. And the labs don't even acknowledge when you're less than stage 3. And because they use creatinine,
a
lot of them are already stage 3, even though the lab says they're normal.
Right.
Normal.
Right.
Normal's a GFR of 90 to 100, but these are part of the problem. The wrong lab work and the perception of what they think they're looking at versus what's hidden behind it. So
exactly.
I didn't have much knowledge. I'd been mentored just casually as a friend of William Finn, who's retired. He's at the University of North Carolina, well-published, famous nephrologist, and he pointed out, some things you could do. Mm-hmm. And that's what I did for my dad. He also told me a dirty secret in nephrology, but I won't share that with you because it'll get nephrologists upset. So I didn't know the best way to go about it, but I knew that niacin was good for kidney disease, but he needed the acidosis control, sodium bicarbonate. Mm-hmm. I wasn't aware you could get it in tablet form, so we took the Arm & Hammer baking soda out of the closet, the cupboard, and spooned it out, a couple teaspoons with each meal, and 2 Tums he'd chew up before the meal. My mom was the compliance cop and made him do that before he could eat. Mm-hmm. And his GFR was already 19. When you slip below 15, they start talking about dialysis. And at some point around there, you're usually referred to a nephrologist. So I was determined to not let him go there. And he was kind of a grumpy Scotch-Irish World War II veteran, and he'd snap short fuse and said something like this to my mom: I'd rather die than go on dialysis. And I told Mom, don't worry, I'm not going to let this happen if I have anything to say about it. So I thought, well, that'll stabilize him. He won't get worse. He won't drop below 15, no dialysis. But what I hadn't anticipated was he started going backwards rapidly. Wow. In fact, I remember one of the first labs was 24, which is about 5 points above where he was. Right. Long story short, he ended up at 61, a GFR of 61.
Wow, Steven.
And I was in there to see it when the labs came in. Dave loved to tell me when things interesting happened at the lipid clinic, because I was down there in the evenings after work. And I ran down there and because he didn't even tell me exactly. He said, "You're going to want to see this."
Uh-huh.
And I looked at the creatinine and I calculated the GFR and went, wow, 61.
Wow.
At this point, he was, have to do the math. He was 86.
Wow.
He lived another 7.5 years, never went to dialysis. And you consider the prequel, the heart attack, open heart, stents.
Right.
And he was in early stages of congestive heart failure, but really the niacin and fish oil bailed him out. A lot of people think that's impossible. They don't read enough literature. It's in there. And I thought, wow, it's great for my family. Why don't we do this for everybody? Well, that's the problem. The system is wired to not favor getting good results with a patient. A lot of people are starting to realize that because the lab work is largely obsolete or unreliable biomarkers. So I learned very quickly what to spot for cardiac risk and what to spot for kidney disease. And I tell patients, you have kidney disease, it's like a wagon wheel. You're in the middle, the hub. All those spokes are what brought you there. You might not have every one of them, but if all they looked at is your blood pressure and your blood sugar, diabetes, prediabetes, they're probably missing half of what brought you there. And if that's all they're managing, they're missing an opportunity.
Right.
And the acidosis is 86% of them. Might as well just give them the alkali because it's difficult to overdose alkali. And there's far more benefit than risk there. So you just look at the CO2, as long as it's less than 28, they're appropriate.
Okay.
Same with thyroid. Not only do they leak the thyroid hormones, whether it's from the thyroid or from supplementation, you're barely staying ahead of it. Plus, the blood work is not reliable because the best measurement to determine low thyroid is the body temperature at rest. So I have them put a thermometer under their armpit. This is the old Dr. Broda Otto Barnes basal temperature test. And I love it because it's so reliable. And I have the patients get me 5 readings. That way, if 1 or 2 weren't agreeing with the other ones, 3 of them will be almost identical. And it just gives me a sense of where they are at baseline.
Right.
And almost every one of them is low. 97.8 is low.
Wow.
They come in with 96.5. They need therapy. The blood work, I look at it, says they're normal. So why even bother to look at it? There's information in there, but I want to know, is it appropriate for treatment?
Right.
And you ask them questions. Do you feel cold? Do you get brain fog? There's a huge list. When you correct it, the loss of protein in the urine, which is probably the most important marker, decreases, goes backwards, almost a stage. And the GFR goes up. Niacin, same thing. It's antiproteinuric, so it corrects that, or at least improves it. The GFR goes up. The parathyroid hormone chills out if it's elevated. And if you have access to FGF23, which is a marker for early marker for damage from elevated phosphorus, it'll take care of that. Well, niacin lowers phosphorus. Niacin lowers PTH. Niacin increases GFR. Niacin improves proteinuria. And the FGF23, there's one of the only things that'll bring it down is niacin. So if you use a cocktail of 3 things, niacin, sodium bicarbonate, and calcium carbonate. Calcium carbonate, the only restriction there is you don't want to use more than 5 grams, which is guidelines, because it's 2 grams of that 5 is calcium, elemental calcium. And that's the limit. They may lower it, but it's not a big deal giving them calcium if you're controlling the phosphorus.
Right.
Because if the body's saturation of phosphorus is controlled, that's what causes calcification and brings down the kidneys.
Right.
So if there's a little extra calcium absorbed, I don't view it as a problem as long as they don't go above 10.4 on the blood work. And it does stabilize the parathyroid because there's receptors there that the calcium binds onto, and it's pretty cool.
Yeah.
You're hitting 20, 30 parameters. And I forgot lately, we probably have 100 cases now. I have 25 the nice colorized representations of advanced lab work before and after, because it's quite often difficult to also get the proteinuria. That's a urine catch. I have to kind of assess them on the blood alone, but I have a cystatin C and the creatinine, and they never agree. The creatinine always says one thing and the cystatin C says another. So I calculate the GFR of the cystatin C if I've got one. And I had one fella in Sacramento area, I think it was Lodi or Lincoln, California. This is near the Bay Area up in Northern California. He went from a GFR 30 to 130. I couldn't have been happier. I was like a little kid at Christmas. Oh boy.
Sure. Yeah, right.
And I thought, I wonder how often you can see that robust of an improvement.
Wow. Wow.
We pressed forward because that was 2017. And now I'll send you a little grid. It's got like just simple scorecard before and after, no full name, just like Jim K. And then the time, the days between. Well, that guy in Sacramento, it wasn't even 3 months. It was 74 days, I think.
Oh my goodness.
And I thought, is it persistent? Well, the provider said he pretty much stayed at stage 1 moving forward. As long as you don't take your foot off the brakes, the car doesn't move. And that's what I tell the individuals. But it's pretty rewarding work.
Yeah.
I probably make less than most of my patients. I almost don't care. My wife does. In charge of the checkbook. But I read constantly. I try to find time. I download medical literature, journal articles daily, 20 to 100 every week. And it's hard to keep them organized, and my storage is almost always full, and I have to find clever ways of storing it in the cloud or whatever. I'm 70, so I'm not very good at technology, but
Steven, I have a question for you real quick. What is it specifically about this concoction of these 3 substances together that actually improve the kidney function? Can you tell us from a clinical perspective quickly, but more so patient perspective? Like, what is it about these 3 chemicals? Yeah.
I'm a horrible nerd. I apologize.
No, we love nerds here. We love nerds. Go ahead.
I have to switch gears from technical to layman language. When I talk to a client, doctor wants me to talk to one of their patients. I dummy everything down. Not dummy, just plain English.
Different language, yeah.
Yeah. When you get kidney disease, your body is starved for alkali. What do I mean by that? Alkali raises your pH, acid lowers it. And they're always low. And it's hard to spot because they call it hidden acidosis. So you have to know what to look for. It's the CO2. Or if you have a urine citrate. That damages everything, not just the kidneys. It's bad for your brain. It's bad for every cell in the body, because now you're damaging tissue and your muscles can waste away. And, malnutrition is a common thing with kidney disease when you get late stage. Well, you correct that because the kidney no longer can make enough bicarbonate, alkali, to keep up with it. And the rest of your body's fighting. So you can tell you're acidotic when the alkali in your respiration, the CO2, or in the urine when you do a urine cup. If that's low, that means your body's conserving it. It's holding on to it. So now it's compensating, but it's still acidotic. That covers the sodium bicarbonate or, baking soda. The calcium carbonate, the carbonate's a mild alkali, but it's the calcium you're after. It has a positive charge, 2+. It binds onto the phosphates, which I believe have a 4 positive or negative 4 charge. So, one phosphate requires 2 calciums to bind to it. Once it's bound, they call that a metal salt, because calcium's technically a metal. That won't separate anymore. It'll go out when you have a bowel movement. And that's where you want it. You don't want it getting pulled into your blood. But you can only go so far with the calcium. And there's always some phosphorus in the food that gets absorbed through the intestine. So what do you do about the residual amount that can still get into your bloodstream and cause kidney damage? By the way, it causes heart disease, loss of cognition, calcification in the arteries and the valves. Well, you got to get it down to normal. 5.5 is the goal, but I try to get them to 3 if I can. And I've done that many times, not all the time. But niacin doesn't bind the phosphorus. This is the cool part. There's receptors in the lining of the intestine that allow it to be pulled into the body. They're called sodium phosphorus transporters. Niacin downregulates them. It's pretty cool.
Wow, right.
So I'm using 2 separate mechanisms to control the phosphorus. And by the way, this isn't voodoo or witchcraft or
Woo-woo.
malpractice. It's all in the medical literature. Just hardly anybody in the U.S. does it. Besides, nephrologists are focused on dialysis chairs. At that point, they really don't see the opportunity for prevention. And I'm not going to disfame them, but a friend of mine we're going to be publishing with Dr. Sampath Kumar in India, and I think you're on the webinar.
It was, yeah.
Yeah. What a cool guy.
Yeah, really amazing guy. Yeah.
He was one of the few nephrologists that used niacin, and he had more publications that he authored than any of the other nephrologists that published on it. So I said, that's the guy I need to meet, because there's a lot of niacin bashing or discrediting. Right. And yeah, it's difficult to use, but that's not an excuse for saying it doesn't work or it's not safe. That's just BS. So I get him on the phone. He's 9.5 hours ahead of me. So I talk to him early in the morning. And, 9:30 for him is noon here. So I usually wait till like 8 a.m. to call him, because at that point, he's almost done working. And very eloquent, brilliant man. And he's doing the exact same thing, because he doesn't get a enrichment in his income putting people on dialysis.
Right.
It's like every other developed country except ours has a single payer system. Why don't we have one? Ask your political representatives in Washington. So it's a perverse system here. Well, in Canada, Europe, India, prevention's still on the table, because there's not a creation of wealth by certain specialties because you're running procedures. And he still has to put people on dialysis, but he was using sodium bicarbonate, calcium carbonate, and niacin. And he's very conservative about it. He doesn't do anything crazy, and it controls these risk factors I mentioned. What I found out was if you do it based on the blood work and push it to the point where they're absolutely normal or as close to that as you can get, you're getting a tremendous benefit. And that's why they're going in reverse. And niacin's probably the big sledgehammer. The other two are like a little 1-pound sledgehammer. Niacin's 100-pound sledgehammer. It's just difficult to use. So if somebody wants to know how to use it, I recommend you ask me. Don't go to Google. Don't talk to anybody that doesn't have experience. If you want to, say, when's the last time you used niacin successfully? And you get a undesirable response, because very few people use it. I know most of the people that still do. And once you've got them on board for a week or two, you're pretty much home free. And Castelli taught me that. And he showed me some tricks to keep the 2 lipid clinic staff members from getting angry with me. They were already angry with me because we didn't know how to control the hot flash. And I didn't know it wasn't permanent and that it dissipates, so it's less frequent and less intense with time. Everybody's different. Right. So I came up with a sledgehammer to get rid of the hot flash. Day 1, we just got rid of it. And then suddenly the staff members were happy to see me again. And both providers were really leaning on the niacin and fish oil. And we saw very quickly, not only did the angina disappear, but we noticed there was improvements in cognition, a bunch of things. We weren't even paying attention to kidney disease. So later, now, currently, I realize these things are all connected. They're not separate entities.
Right.
And when you correct one thing, quite often something else improves. And one of the members of my team, Dr. Chet Fox, he's been on the board of the National Kidney Foundation like forever. And almost all his publications are related to kidney disease, not a nephrologist. He started niacin. He was only doing 50 milligrams, I think, the first day. He's taking a lot more now. His knee pain went away because he has bone-on-bone arthritis. And he's noticed he has more energy, and he's walking up and down the beach now, and he's much older than me. And I thought, there's another testimonial. Well, I hear that a lot,
Right.
you know?
Right.
Does niacin give you more energy? Does niacin help cognition, fatigue? Yeah. There's like 400 genes in the body that require niacin to function normally. And the National Health NHANES, they call it NHANES. It's like the NIH, same branch of government. They did several studies recently. It's good for Parkinson's. And these are tiny amounts of niacin. It's good for stroke. It's good for reducing cancer risk. It's good for reducing diabetes risk, which is counter to what most doctors think. It's just if you don't know how to use niacin, yeah, the glucose might go up. But long term, it actually, the A1Cs come down. Duh. You know, so it doesn't cause diabetes. It's just, you got to administer it in the right hands, somebody has experience. And what else? They showed that it reduced the progression of kidney disease. There's a lower incidence. I mean, type in NHANES and niacin in the two top windows of Google Advanced Search. It'll blow your mind. Because there's 6 publications that have come up right away. And these were in the last 2 years. And I save all this stuff because it's not like I want to settle an argument or make myself look good. No, it's just to clarify where the truth actually is versus popular dogma.
Yes, exactly.
And I run into it every day. Niacin's a redheaded stepchild. No pun intended.
For our audience, a little bit of an idea where acidosis may come from. Why is it prevalent now? I know I've had kidney disease since I was 19. I'm now 48. I'm now 2 transplants in. None of this was ever discussed with me. Acidosis, my diet, none of what you're talking about was ever discussed with me.
But the big player is the American diet, mainly protein. And that's why they try to restrict protein. Personally, I think it's because they don't know how to control the phosphorus and the acidosis any other way. So go vegetarian the rest of your life. Good luck with that.
Right.
I'm not defaming or overly criticizing doctors. No, I'm not aiming this at doctors. The ignorance comes from the system. If they work you to death, how the hell are you going to read 5 medical journals inside of a week? They used to. I don't see much of it anymore. I feel that's my job. If I have any time, I do it. And I store everything I download and I label it so it doesn't get lost in there. I have, I think, 1.2 terabytes of medical literature. But the acidosis comes from the American diet, and it's mainly protein. So you have to counter it, and you need the protein to stay alive. It's not directly toxic to the kidneys per se. It's what comes with it, the phosphorus, the acidosis.
I see.
And I don't believe in excessive amounts of protein, but up until recently, they were still saying about the size of a deck of cards, like, you know, a small breast of chicken or salmon's great. You know, grass-fed beef, you know, healthy, organically raised beef or pork. But you got to counteract the risk factors, not be preoccupied with the source. Because you're never going to get Americans to stop eating meat and eating carbohydrates.
Steven, I got a quick question. Do you think that stress contributes to acidosis in the body?
Probably indirectly. And now, you know, the way my brain works, as soon as I'm done here, I'll probably go to Google and connect the dots, I'm sure. Because stress affects everything. It increases inflammation, oxidation. It damages the sleep architecture, the length and quality, and so forth. So almost undeniably. And it doesn't have to be directly causal. It could be a risk factor for it. It's still something to consider. But if you can correct as many risk factors as you can find, it's intuitive you're going to see an improvement in health and longevity and prevent things from occurring, or at least reduce the chance of them getting worse once they've had it. I mean, we had people that had heart attacks already in the lipid clinics. And I got really angry because I won't name the specialty, but they kept taking them off the niacin. And they'd go in for a cardiac workup. And that's the first thing they do, because that's the one specialty doesn't get it. But these are guys that were younger than me. And at the time, that was like a 30-year-old Italian guy. He had LP little a. You don't want them to be on Lipitor or Crestor. And that causes kidney disease and heart attacks and stroke. And statins raise it. So we had him on a lot of niacin. His angina went away. This guy had stents placed, I think, 5 times.
Wow.
Now, you can't remove stents.
Right.
And you can't stent the brain. So the stroke is just a brain attack.
Right.
You either get claudication, peripheral arterial disease in the extremities, the legs, or you get a heart attack, or you get a brain attack. We can't stent the brain. So if the stent doesn't have any long-term value for heart attack, there's no long-term value in the vasculature in general. It's just a billable procedure. If you get the prevention on board in enough time, you can keep these things from occurring, or at least after the fact, slow it down. Niacin is one of the best things after a stroke. At the, Henry Ford Health System in Detroit, there's Dr. Chen and Dr. Chop. ChenChopp. Go to Google and look them up. They have all this stroke data on niacin. So some uninformed individual, I won't condescend, if he hasn't read that, don't listen to him. Recommend that he looks that up, because it's fabulous data. Niacin restores brain plasticity. It accelerates the repair of the neurons after the stroke.
Wow.
So imagine taking it beforehand. And now they know that the myelin sheath, so you got a neuron, and there's like a fatty wrapper around it called myelin.
Right.
And that protects it. When that falls apart or gets damaged, niacin accelerates the repairs, mainly by removing the debris. But they figured this out because they were treating tumors, brain cancer, glioblastomas, and shrinking it with 6 grams of niacin before everyone gets shocked and goes, FDA still has the indication in place for 6,000 milligrams a day of niacin, as long as it's immediate release. There's like 4 brands, but it's the formulation that's important. Well, it's shrinking brain tumors. Come on. And I was kind of stunned when I saw that. But the mechanism is your immune system's out of whack in a lot of disease states. So the inflammation's up.
Right.
There's 2 basic categories of macrophages, white blood cells that eat pathogens. Well, the M1s create inflammation, and they're actually not helping the body forestall or prevent damage, because they're there to release alkaline compounds like peroxides and hypochlorite, which is like bleach, have these blue azure granules that store it. And when there's a pathogen, they release it. Well, in other pathological states like cancer, heart disease, and so forth, they're activated. Niacin turns them into an M2, which is anti-inflammatory, and goes in and picks up the debris. And they appear to selectively go after dangerous cells. A lot of research on it, but they had a neat little cartoon-like picture of it showing the smiling M2 and the evil M1. And niacin repolarizes. So that's affecting the entire body in almost any pathological state, because you reduce the inflammation, that's good. If there's damaged cells or dangerous cells, and they're more likely to be consumed by the M2, that's a good idea. I didn't even know that 2 years ago.
Wow.
I keep reading this stuff because it's interesting, right?
Yeah, right. The fact that you continue to research and you don't have a specific incentive, I think, is what makes you so unique and powerful. And I was so happy to talk to you because as somebody who's experienced CKD myself and has been a part of many prestigious institutions here in the West, I'm just so hopeful because the narrative around CKD is just so glib. You've had a way to traverse within the system, but you still are able to hold this outlier approach is really what fascinates me and gets me excited for other patients and providers to really hear what you're doing.
Well, God bless you. Doing what I do, integrative, functional, holistic complementary medicine
Mhm.
is still not in vogue.
Right now.
Although Orthomolecular is publishing us again, I think this is the third or fourth. Dr. Pizzorno, Bastyr University Naturopathic Society. He's got the largest integrated functional journal. They're publishing some of my case studies later this year. That's peer reviewed. It's on PubMed, so it's coming around. But they look at it like voodoo.
Yeah, they really do. They really do.
I say it's a bit like early Christianity, and the Romans are going to crucify you if they find out that you're not worshiping their gods. So
exactly,
we scurry around in the middle of the night and go into a cave and worship by candlelight, and we look like crazy-eyed, unshaven heathens, because we know if anyone finds out, there will be criticized at the very least. Well, it's kind of the way it is,
Yeah,
and then they scurry off in the dark and go home and pretend that they're not Christians.
Exactly.
I kind of confront it head on, because at the end of the day, if somebody wants to criticize me, I was doing a dinner program, and so well, let me put it this way. When you're presented with somebody who had a heart attack already, how often did they have another heart attack? And they got really angry. I said, well, I have outcomes data. I'm not a specialist like you, but I work with specialists. And I said, we have it on file, and you're glad to see the data. He got up and left. And a couple of guys up front went like this.
I've gotten a lot of care from prestigious physicians and have even been in relationships with certain doctors. And one thing that I've really discovered is that we like to tout certain ideology that sounds good.
Yeah. And, I have to credit a lot of people, but the one quote I always like to say, because it came from Brad Bale, and he and his partner, Amy Doneen, are just wonderful people, brilliant people. I used to go to their, they'd have programs, and Cleveland's not far away, so I went there a couple of times. We got to be friends. I haven't seen either of them in a long time, but Brad used to say, and I'm going to try to affect my best Bradley Bale accent, he said, the guidelines will get you killed. That's absolutely true. Oh, you got a cholesterol problem. First of all, that's not a very accurate term. It's a particle problem. Well, what do the guidelines say? Put them on Lipitor or Crestor. And put them on a statin. Not a good idea for everyone. For me and my brother, it raises absorption because we have a genetic defect. 1 out of 4 people. But it's probably 40% of cardiac rehab. That's an enrichment because it's causal. That means I'm recycling cholesterol through my gut. When I suppress the liver from making cholesterol, the gut goes into high gear. Right. Now you've messed everything up. Well, it's not just cholesterol. You're absorbing plant sterols. The technical term is xenosterols. Right. It's not easy to order, but there are a couple of ways you can get it. Boston Heart Lab still survived in the advanced testing market, and they got an elegant panel there. I can see how much the liver's making and how much the intestine's absorbing. And then they're a good candidate for one of 2 therapeutic options. LP-A. They've shown several times it increases risk when you add a statin. Most of who's don't believe that, but they don't read enough. They think they do. Well, it turned out the one paper by ZHU, they actually randomized and looked long-term, and the people where the LP-A went up 10 milligrams per deciliter, which is about 24 nanomoles. If it went up that much on the statin, there was a 2.29 times increase in overall risk of cardiovascular endpoints, including death. Why would you do that if you knew that? Well, the guidelines said to put them. The guidelines don't tell you anything about LP-A. They still think it's experimental. Right. Well, guess what? There's 5 drugs coming out, so suddenly the guidelines will make recommendations. And in fact, the European guidelines and Canada were way ahead of us. In 2009, they said 3 grams of niacin is the only thing that works for LP-A. Wow. And that costs 18 cents.
Yes, I can see how that's a major problem here in the West.
And you know what? The new drugs remove what makes you unique. You got a bad particle, and there's good ones, but let's talk about the bad ones. ApoB, apolipoprotein B, is like if I took my wristwatch off and wrapped it around a baseball. So there's only one per baseball. If I measure ApoB, the protein, I get a discrete specific number of particles. Well, a small number of them are LP little a if you inherited it, which my wife does. It's lipoprotein little a, lowercase a. Incredibly dangerous. It's genetic. Lifestyle and exercise do nothing. And most of the cholesterol drugs don't move it at all, and the statins all raise it. So why would you be concerned about that? Well, even if your LDL, which is not even a real number, your ApoB is at goal. If 16% of them, 16%, and that's about the highest proportion that could be LP-little-A, is LP-little-A, you're still in trouble. And the only way you can lower it is niacin. With these new drugs, LP-little-A is kind of like the ApoB, but it's attached to it, and it's like a tail. It's a glycoprotein, a sugar protein. It's like Scotch tape. It screws up your ability to dissolve a clot because God made mechanisms to dissolve clots. Now you're just bound to the clot buster, the thing that thins your blood, because the tail is almost identical to plasminogen, which breaks down clots.
Right.
So now you not only can get atherosclerosis, but you can have a thrombus. And that's really about 75% of the heart attacks are blood clots, not some lesion that fills the artery. That's a myth that's perpetuated. Most of the heart attacks are from a tiny little bump full of cholesterol that doesn't obstruct blood flow. It makes a clot. You go downstream in the artery, and the first obstruction, or fork in the road when the arteries branch off, it'll catch there. Now you might have a heart attack or stroke. Most people don't know that, and they've proven this. Well, if you keep the thrombus from forming, that's a big part of the problem. And the atherosclerosis that causes unstable, highly inflammatory, hot, temperature's hot, that plaque, because of the inflammation, it'll bust and throw the clot downstream. You got to stop both. You got to stop making the little lesions. You got to stop allowing the body to form clots without thinning them out. Well, niacin does both. And if you look at these drugs, they leave the particle behind. They only remove the tail, which is the little a. Well, if you remove the tail, you still have ApoB. Well, guess we still need another drug, maybe 3. Niacin's still the only monotherapy, and I'm getting a lot of backlash from this, but it's just lack of familiarity with literature. It's the only monotherapy that moves all the bad particles, including LP-little-a, in the correct direction. The expert on this you need to check out is Soterios Sam Zemeckis in San Diego. Brilliant guy. He gets backlash all the time because he warned us about the statins increasing LP-little-a. You want to know about LP-little-a? Read up on him. I have a folder with all his publications, and he's really kind to me. He sends me, the latest literature, because sometimes they charge for the download, and he'll hook me up so I can keep up on things. Well, he used niacin for a long time, and he said some of his patients survived 30 years on niacin. They had really high LP-little-a. That's the worst cholesterol disorder there is, by far. And if you're only removing the tail, now it's not an LP-little-a, but it's still an ApoB, you still have a problem. Niacin is the only single medication moves all the bad guys down and all the good guys up. And it reduces inflammation, oxidation. It does 1,000 things. And there's more publications on PubMed in any given month where they're researching niacin again than almost anything else. It's overwhelming. I mean, if I punch in, limit it to 1 week and do a search on PubMed or Google, so I'm not looking too far back, there's 20, 30 papers this week. I have a hard time keeping up with it. I just download them into a folder so I don't lose them. And then when I have the luxury of the time to read them all, I do. But I promised my team, I'm not the business guy, this is the 3 things I mentioned for kidney disease. Let me know if that's in focus.
Yeah, we can see it. Kidney defense.
Okay. Yeah, it was kind of tricky to figure out the ratio. So I had to kind of take the average amount of usually administered. But some people are taking 4 capsules a day. You take it with food. And some that are more severe or resistant to therapy are taking 6. But
Stephen, what's in that formula?
Same thing. The old days when I first figured this out, I was kind of proud of myself because I kept my dad off of dialysis. I said, I need a tip sheet because I had a tip sheet for niacin. We were using what Castelli showed me and a couple other lipidologists, Alka-Seltzer and applesauce, because the Alka-Seltzer will control 2/3 of the people that get a hot flash, but it's just a prostaglandin suppression. It's really an aspirin that's buffered, no upset stomach, and it's aqueous, so it gets in your body quicker. It's dissolved. What about the other third that have a hot flash? Well, you need to get rid of a serotonin and a histamine pathway, flavonoids. And I remember at the lipid clinic, they said, almost everybody on Coumadin has ischemic heart disease. What are we going to do? Can't give them an aspirin, right? Coags will mess up the INR. Well, I didn't know what to do, but I researched it. Finally, I accidentally found it. It's flavonoids. So we give them a little applesauce, 3 tablespoons, and an Alka-Seltzer. And the tip sheet was called the Alka-Sauce Protocol, Alka-Sauce. Now, it wasn't like brains or anything. It was just I noticed when I made it too martial, like a military order, patients didn't like it. The girls in the staff didn't like it. So we feminized it a bit. I said, I'll make it funny. Italicize it, make the letters real big at the top of the page. And it was a miracle. Immediately, niacin became easy to use. And then when the kidney protocol came out, I said, well, how do I name that? Well, there's 2 things in there. Baking soda, sodium bicarb, with Arm & Hammer, and Tums. I said, let's call it the Tums and Hammer protocol. And, some of my doctors might see this and they'll laugh because they know they've been using it. And I'd get calls like 2 years after I met them, like in California or Florida. One of the members of my team I hadn't talked to in 6 years. I got an email, and I can't quote it exactly, say, hey, is this the right email? We haven't talked to her in a while. We should get together and have a conversation. Oh, by the way, I've been using your Tums and Hammer, and everybody that I gave the tip sheet to, the kidneys are going backwards. I didn't know that he couldn't do hormone replacement therapy. What do they call it? Bio-T, little pellets. They make a little incision and put it on your gluteus, on your butt cheek. Anyway, I had it done a couple of times. It's not considered appropriate to treat patients with advanced kidney disease. Well, he solved the problem by using the Tums and Hammer. Now he's part of our company because he saw a lot of case studies. And I'm very dependent on working with doctors. Hey, I'm not an MD, but I'm very blessed that so many doctors don't just ignore me out of hand. They consider it reasonable to talk to me. And when they see the case studies and they see the compendium of data, they don't have time to read half of one Dropbox folder.
Right.
And I have like 60 Dropbox folders.
Right.
And the one for niacin has 20 separate Dropbox folders in that Dropbox folder. And last time I looked, there was like 120,000 reprints in there, separate reprints. And that's invaluable. It's like my personal medical library because that's where I get the ideas. And then I find some provider who's got a forward thinking attitude. I say, I don't think there's a safety problem here. You tell me if you think it's okay. Let's try it. And then if it works, it's like, hey, 90% of what I do is not prescription. I'm not against prescription, but if you can't get it or you can't afford it, what are you going to do? And besides, nobody seems to appreciate the fact that none of these drugs are cut from whole cloth. They're not original ideas. Merck copied Red Yeast Rice and made Mevacor, and then they went to the FDA and tried to ban their competitor from China, Red Yeast Rice. Every drug is copying nature. So I tell patients, God gets it right the first time. The pharmaceutical companies screw it up, and then they charge too much for it. Wow. That's kind of a blunt object to hit the industry, but they probably deserve it.
Yeah. Thank you very much. Trust me, as a patient, we're looking up to people like you who are really out to help and to face the system. And, I want to ask you a question besides all this awesome information. I mean, I'm connected to so many patients, and I know this information is going to do one of two things, or maybe both. Is, sometimes the truth pisses you off, excuse my French, before you're able
every day
to digest it. And who have kidney disease, who are on close to 10 medications at least, because one causes a side effect of another, and then another, and then another. And it's just an endless stream of pharmaceuticals.
Right. Well, again, I have to say, don't blame the provider. Don't blame the doctor, particularly if they don't have a cash practice. Mm-hmm. Most doctors still depend on insurance companies. What are you going to get done in 12 minutes twice a year?
Right. Right.
If you got a complex patient, they can barely read the lab work and do a brief summary of the patient, and they're out the door, make an appointment, see me in 6 months. Mm-hmm. A lot happens at 6 months. I watch this all the time. Mm-hmm. My 2 lipid clinics were identical to that. The only difference was these guys had a tremendously superior attitude about doing more. And they knew I was a nerd and I was their friend, so they said, let's just do that. No money exchanged hands. You literally can't bill an insurance company for doing prevention. They position that they're offering that, but they don't. Because if you try to order better blood work, they thwart you at every turn. Excluding Medicaid and Medicare, commercial insurance companies have to keep a 10% margin for shareholders. And the CEOs in the insurance company do well when they can keep it 10% or less. So where did the other 90% go? Well, certainly didn't go towards your care. Mm-hmm. Mm-hmm. And that's a pretty sobering thought. And a friend of mine, I forget what specialty he is, but he made an anecdote. He said, commercial insurance is like this. When you're really young, you don't worry about sickness unless something pretty serious happens, and type 1 diabetes, whatever, genetic disorders. You kind of cruise along, and eventually you're off mom and dad's insurance. You get your own insurance. You're working. Maybe you're starting a family. We're sort of on a slow moving treadmill that picks up speed as you get older. Mm-hmm. And the insurance company does as little as they can to tinker with you. Oh, that costs money. So they find clever ways of not providing, or denying that test, denying this, denying the drug, deny. Mm-hmm. And then things get worse and worse and worse. They're maintaining your disease, not stopping it or preventing it. Mm-hmm. Mm-hmm. And when you get to 65, you fall off the end of the treadmill and you have all these problems that commercial insurance didn't assist your provider managing, and Medicare has to try to claw back time and resources to figure out how to help you. I love it when somebody's got Medicare. I'm on Medicare because almost anything they really need, you can get. Mm-hmm. Mm-hmm. The testing, I can order wonderful blood work. Mm-hmm. The provider's the licensed provider. He's signing on the paperwork, but it's like a Boston Heart diagnostic panel is sort of the end of the road. They still accept insurance. Most of the other ones are cash based entirely, but it's an elegant panel, and I'm spoiled because that's pretty much all I've used in the last 10 years is, Berkeley, Liposcience, Health Diagnostic Laboratory, True Health Diagnostics. There's a bunch of them. The only one that survived the rigor of the competitive industry and regulatory and everything else was Boston Heart. God bless them. It's beautiful laid out panel, and everything I really need is in there. It's got the absorption panel with the synthesis panel. Are you a high synthesizer in the liver or a high absorber in the gut? Lipoproteins, conventional cholesterol panel, inflammation, oxidation, everything. I got a cystatin C for the GFR. I mean, it's wonderful having all that pathology at your fingertips on every patient. Yeah. I can't get it on every patient anymore. So I do the best I can. And right off the bat, I'm not brilliant. I'm not a savant or whatever. What I do have that might be special, God gave to me, is curiosity. It's like Sam Jaffe in that black and white science fiction movie. When he finally meets the alien at the end, the day the earth stood still, the alien says, so you're a man of faith. This is the Einstein character in the movie. He goes, oh no, it's not faith, Klaatu, is the alien. He said, it's not faith that makes good science. It's It's curiosity. And so God gave me the curiosity. So whether I'm smart or not isn't important. I'm open to new ideas, and I know a good thing when I see it. When I read a journal article, I see the components in there that kind of stand out.
Yeah.
And it's stuck in my brain because I have mild Asperger's. So I have a lot of awkward social tics and behavioral stuff. Ask my wife. But it's a tool.
Yes, it is. Yeah.
Because my retention's good. I got 91 percentile on the boards. I got published. I was much younger back then. And I didn't let it go to my head. It was because I wasn't just studying what I needed for the boards or to put somebody on the heart-lung machine. I was grabbing on any literature I can get. And that's back when the medical library at the school, when I went to Columbia Presby, I'd put my orders in every day. There was no, internet. I had hard copies, and she liked it because I put her to work. Nobody else in the school asked her for literature. I always had a stack. I mean, several times a week I'd go in there and I'd grab it and take it back to my apartment and read everything. And my roommate would say, "You're killing a lot of trees, man."
Yeah.
I remember I came home to visit my fiance, and I barely made it back because of a blizzard. And he moved out into the front of the apartment into my room looking at the street. I said, "What are you doing?" He goes, "Man, they're scraping the streets." I said, "They call that snow plows." He was from down south. He'd never seen 2 feet of snow. But I digress.
So how about this? Let me reframe the question. You said that you were gifted by God with this curiosity. And that's one thing as a patient, when I do my own research, because I'm a patient, I'm not a healthcare provider per se. But I consider my life my own scientific experiment, and I do my own scientific research on my own life. I don't just automatically give over all of my autonomy to someone who went to school for how to be healthy. I also do my own research. And a lot of times if I bring questions to my providers, the curiosity is just not there. And in fact, I get a lot of short answers of, "Oh, well, that's just charlatan, and that's just this, and that's just," and I guess my question is, as a patient who's curious myself, I guess my only option is to find other providers who also still maintain curiosity.
Yeah, I think when they aren't concierge, and most of them do some form of integrative functional, complementary, holistic, and naturopaths are great because they've already made that leap. And there's a number of states they're licensed in and can order blood work and bill insurance. That's a better deal. Now, again, I don't blame the provider. And I know I have to say that many times because it might come off like I'm saying they're stupid or something. No,
Right.
They're handcuffed, gagged, and chained to the insurance company. That's really who's controlling the care. And they know it. And that's why most of them are miserable in an insurance-based practice. There are ways out of that. But what I say is they might want to open the doors in the evening. Most people are done working, and have a cash-based practice. You're still a licensed provider. You're still opted in with insurance. They call it opted in with Medicare, which cycles down through, you can now bill insurance. And everything that's not paid for there, the patient has to understand they need to pay for and have reasonable prices. Direct to primary care is probably one of the best bargains. One of my best friends here in town was, I think, the first DPC provider. For a while, it was $75 a month. Not bad.
No. Yeah.
I think it's 100 now, but he's giving much better care. He's giving you an hour on the encounter every time you see him. He draws blood in the office, and he uses advanced testing. He even has a small pharmacy in there for common things that get dispensed, but I think it falls to the patient to find better solutions. When I'm trying to find someone to work with, if I haven't already been recommended by their doctor, so I don't know the doctor, how do I help the patient? I need to work with the provider. So I go to my directory, put their zip code in, and find a naturopath or integrative function provider, or at least somebody who's concierge medicine. And then they're going to need to get their wallet out, because your insurance is not your best friend. It's actually probably your worst friend. The exception being federal. When you get into Medicaid, Medicare, it more reflects what you see in Canada and Europe and so forth. Well, most patients still think, well, the insurance should pay for everything. Why would I? Well, you got copays, right? Did you ever get denied? Oh, yeah. Well, that's just the beginning. It's not going to get better.
Yeah.
They're constantly trying to shave expenditures down to maintain their margin of profit because it's a profit, a for-profit business running a commercial insurance company. And I don't even think about that hardly at all anymore. I just try to figure out, here's the patient, here's his or her problem. How can I circumvent the system to get them the best care?
Yeah.
And then I almost always have a friend I can work with. Like lately I've been working a lot with Dr. Mary Mignon. She's in New Orleans. Man, she's wonderful. And it used to be I was on a face-to-face basis with providers. But 25 years ago, there was maybe 5 or 10. Now it's probably closer to 200 or 300. And 90% of all of them I've never met.
Wow.
Face to face.
Right.
And they're so busy, they shoot me a text or an email and say, will you call this guy? And I think about the money because that perverts my train of thought. I think about the patient and what is possible that can be done. And then I reach out to colleagues and whoever and say, hey, have you seen one of these? You've seen one of these. When they're new, they're still kind of clinging on to that old belief system. I'm like, look, first of all, ask them if they know how to use niacin. They'll say that. Say, well, how many people did you start on niacin this week, this month, this year? How many of them are still on it a year later? Well, you're going to get a response that'll tell you whether it's the right person or not. That doesn't mean they're a bad provider. It just means they don't know anything about niacin or never learned how to use it. A lot know how to use it, but they don't have the time anymore. 12 minutes, can't do it. I give the patient an hour because you got to stress the side effect and why it's not dangerous. It's actually beneficial, how to manage it, set their expectations. And then the other thing is if they're willing to go outside of the box. And the one thing I run into all the time is the blood work. Well, they order the right blood work. Don't give me an LDL. I want an ApoB. And if you're going to order that, you might as well check the Lp(a). And if they're suspicious, they'll say, how's the family history? Oh, horrible. I say, order it. You got one male relative, brother, cousin, grandfather, father, uncle. They had a heart attack before 65. Better than 50-50, there's Lp(a) in the family. When I roll the dice and make that bet, I win every time because it comes up in the man because estrogen protects the woman until menopause. Then the Lp(a) jumps up more. Kathy, my wife's doubled when she went through menopause. She's right around 500 nanomoles. Pretty elevated. I got it down to 120. Now that ain't 70.
Right.
But there was an exponential decrease in her risk. Her thyroid got better. She was mildly low thyroid. And there's a couple old studies where they used niacin and cholesterol, and they noticed people were going euthyroid even though there was no change in medication. I thought there's got to be thyroglobulin, something's going on there. And there's another issue. If you're acidotic, the inactive, it's like a storage particle. It's got 4 iodines, T4. T4 is not active. It's active when you strip off one of those iodines. Now you got 3. That's T3, and that's what goes to the cell, binds to the receptors, and creates the magic. Well, if you're acidotic, T4 sits there. And the deiodinase that removes the one iodine doesn't work. And they're all acidotic with kidney disease. Duh. They're leaking the hormones, and the ones they're making aren't working very well.
Wow. Yeah.
And when you correct it, the proteinuria goes down, the GFR goes up, you feel better. Lp(a) comes down, ApoB comes down. That's a very inexpensive way to improve lipid management is thyroid. Nobody ever thinks of it. They used to teach them that 30 or 40 years ago. High cholesterol, they probably have low thyroid. Quite often.
Yeah.
And I just want to know that we've validated by an accepted metric that they are indeed low thyroid. Basal temperatures. Same thing with insulin resistance. I want to know not that just that they have it, Is it mild, moderate, or severe? We'll have them stick their finger 1 hour after a mixed meal, dinner. Make sure it's not all health food. That's pretty easy, right?
Yeah.
Got some carbs in there and some fats. Potatoes will really provoke a long spike in glucose. And then stick your finger an hour afterwards. If it's around 155, you're moderate. Slightly less, you're mild. Higher than that, you're probably severe. And they validated it against the formal oral glucose tolerance test, which insurance has to pay for, and you have to go to a lab to do it. And it turned out to have specificity and sensitivity in the 90% range. Pretty damn good. And it's a quick way to rule out that it's there and how severe it may or may not be, because you really can't tell with the A1C and the fasting until they're pretty much approaching diabetes. A random 200 is great, but you waiting for a random 200? Why not actually see what the challenge does and the patient's response to it? And they call it the FFTT. If you go to a lab and use insurance, oral glucose tolerance test, OGTT. The FFTT was done by a guy, I think, in Arizona, an endocrinologist, and he presented it in ADA like 15 years ago. That he had a lot of Hispanic, First Nations, Native Americans, high prevalence of diabetes and kidney disease and all that. A lot of financial issues, lack of insurance or lousy insurance, and it was a burden. And he thought, I wonder if I sent him home with a glucometer, because the reps leave the sample closets full of glucometers. It's the disposables that make the money. So he'd give them the strips and say, I only want 5 readings or whatever, a couple readings. And showed them how to stick their finger and put the little tiny piece of paper and read it, write it down. And he called it the fast food tolerance test, FFTT. He has specific instructions, how many grams of carbs, how many grams of fat. And they'd go home and do it. And that gave them a good sense of where they were, mild, moderate, or severe. So when a patient comes to me, that's an extremely important data point, even if they already have diabetes. A lot of them have these sophisticated monitors, so they already know. But say that's how we know you really controlled the problem, because the A1C and the fasting have some utility. But the most important thing is, how high were your spikes after you challenged your body? Because you're challenging the pancreas, of course, the liver, and the incretin system in the intestine. And if you can't hold your glucose down very well in an hour, the rest of the information is not as important. And I've caught a couple of people that I think had late acquired type 1, because the insulin was really low, horribly low. The glucose wasn't that elevated, but I thought, oh God, he's probably losing beta function. He's not making insulin. And the C-peptide and the pro-insulin were way out of range. If you do the pro-insulin C-peptide ratio, 3.8 is in the red. I forget where yellow tapers off to the green, but you can worry about the red. It was like off the scale. And I went, this guy probably was overlooked. And I told him, you need to get I think it's GAD1. It detects this autoimmune response that destroys your beta cells. I said, you need to get that test. And if they refuse to do it or give you a hard time, you may want to consider getting your credit card out. And I said, and I'll hook you up with somebody that will write the lab order so you can get it. Because once you've got the diagnosis, then you can get a little bit better attention from your insurance company. But, that 1 hour is pretty important because now I can tell there's a bunch of other things going on there. And about a third of the people that have kidney disease in my small universe, they don't even have diabetes yet. They have pre-diabetes.
Right.
And their blood pressure is pre-hypertensive. It's not real bad. And I like genetics to help ferret out what's going on, but it's harder to order than it was 10 or 15 years ago. And paperwork's got to be filled out. Insurance won't pay for it, doesn't want to pay for it. But there's a myriad number of things you can check in the genetics, but I like MTHFR. I'm positive. My brother and I are a 6-7 TT. It explains some of our behavior issues and blood pressure, bunch of stuff. It's a cardiac risk factor. And the other one has a lot of stuff underneath it. ApoE. I'm looking for a single 4 or a double 4 because there's pairs. You either have a 3 with a 2 or a 3 with a 4 or 2 2s, 2 3s, 2 4s. And God forbid you got a double 4. They're usually high absorbers like me and my brother. They need something like Zetia or this L-reiteri that's been re-engineered. Same efficacy as Zetia, and it's good for your gut health. Duh.
Yeah.
My integrated functional people love it because it's not a drug.
Right.
And it tells me that you've got bad receptors, which are like catcher's mitts, microscopic, sitting on the edge of the cell out in the bloodstream. And their job is to grab ApoB particles and remove them. Well, they're defective if you got a 4 or a double 4. So they have higher rates of aortic aneurysm, stroke, heart attack. There's special dietary recommendations, all this stuff. Well, that one test, I'll only run one time, will help me look for other problems.
Yeah.
Because it kind of opens the door and I look in there and go, oh, that's an absorber. I'll bet you 75%. Or, the statin's not going to work because they're not great particle drugs. 80% of their horsepower is in the lowest dose. So why do they titrate it? Money, or just lack of awareness.
Right.
And when you talk about the drugs that came up to treat the flaw with the statins, they're called PCSK9 inhibitors. Well, why did they come up with them? Well, because statins raise PCSK9. Now you're losing those receptors. For every 20 you've got, you lost 10, 20% of them because now the statin's working against you. Yeah. And it doesn't provoke it at the lowest dose. So what's so sexy about that? Almost nothing.
Right.
And niacin's a PCSK9 inhibitor at 3 grams, which is 18 cents. It might have gone up because of tariffs, 19 cents a day. It has about the same horsepower as Repatha and Praluent, and they don't lower Lp(a) very much. I get it down a minimum of 40%, usually 60 to 70, with 3 or 4 grams of niacin, 6 cents a gram. Come on.
Yeah.
You're still with me here, people? What God made is almost always a good idea. You have to know how to navigate it, and you need some nerd like me who likes doing that, because it's like an arm wrestling match. Every time I get them on niacin, I don't win, the patient wins, because the longer you're on it, the better you feel. Exercise tolerance. We have another bottle called Fitness Defender. And actually, they said, can you make the flush worse or longer lasting? I was like, no, that's what I've been trying to stop for 25 years. I thought, yeah, I can do that.
Yeah.
So I took all these natural things that make nitric oxide, and they extend that effect beyond the 30, 45 minutes you see with immediate release niacin, because a lot of bodybuilders take it to provoke it. And it's all about stamina and endurance. Well, Dr. Richard, I don't want to use his last name, that would be inappropriate. He took it and said, took 90 minutes for it to go away. I said, do you think it would help your workout? Oh, yeah. I thought, wow. Great, because I never thought the bane of my existence I would want to amplify.
Yeah, right.
But if you're a bodybuilder and you do cold immersion and you exercise until you have pain in your muscles, if this makes it easier to go further, it might be kind of cool. It's called the Fitness Defender. I'm not very fit. I sit and use my brain all day and not much of my body, but in a former life, I was a drummer. And it's probably the only reason my wife paid attention to me, because I was muscular.
And you had rhythm.
Yeah, I guess I won't go there. You'll have to talk to her. Okay. Anyway, I was going to say this quote earlier because it's more reflective of the system, not so much the providers. The providers are a victim of the system, and then it transmits down to the patients getting minimal care.
Yeah.
Be Jesus. What did he say? Forgive them, for they don't know what they do. And it's not they. The system knows what should be done. They just won't allow it to be done. And it's fighting the system every day and ignorance. Ignorance is my number one challenge. And it's not that they're ignorant people. It's lack of knowledge.
Mhm.
And again, Castelli put it well. I'll send you his paper. It's a great read. I highlighted all the sections on niacin, and
Yeah.
you saw narrowings in the arteries disappear on niacin.
Mhm.
It's the only drug with the indication to do that, by the way. He said it's an epistemology problem.
Exactly. Yeah.
He said, knowledge is like concentric circles. If you've only got the target dot in the middle, you have limited knowledge. But if that's all you're aware of, you're content. I'm never content.
Right.
I'm constantly trying to add on concentric circles. So
Awesome.
I have a more comprehensive knowledge. And the other quote, he said, he's great. I only met him a few times, and he was very kind to me, emailed me. He's retired. He said, there's two kinds of people in this world. He goes, the first kind are always worried about how attractive they are. Does my hair look right? Do I have the most expensive car?
Mhm.
Do people really like me? Do I make enough money? And he goes, the second type doesn't really care about that. They like fixing things. They grab onto a problem, and when they solve it, it's like they've gotten to the peak of a mountain,
Yes.
and they're momentarily exhilarated.
Mhm. Mhm.
And then off they go looking for the next mountain.
Yeah. Yeah. I love it. I love it. Sounds like self-orientation versus service orientation.
Yeah, someday I might actually make a decent living at this, but I'm a man of faith. I think
Mhm.
it will eventually, they'll find me.
Yeah,
And
I believe it. And let's talk about that right now. For anybody watching this, patient or provider, what does it look like to work with you, and how do they find you, and what do they have to do? Give it for the patient part of it and the provider side of it.
Well, there's a lot of overlap.
Yeah.
I communicate much differently with the patient. I apologize. I went technical
No, it's good.
too much, but just contact me. You can publish my phone number and my email. Someday I might have to change my phone number.
Yeah.
But
what is the ideal way you like to work with a patient and provider? Do you like to go through the provider, have them find a provider?
Absolutely.
Will you help them find a provider locally? How does that
right.
work?
For all the right reasons, if they already have a provider that's willing to at least talk to me, great.
Mhm.
Or they referred the patient to me, and it's a done deal.
Okay.
If not, I'll go to my directory and find them a naturopath or an MD or a DO or a nurse practitioner or mid-level
Mhm.
who has a really great attitude. I don't care how smart somebody is. I'm not that smart.
Mhm.
But it's that attitude thing.
Yeah.
If they got a great attitude, we can create a miracle for that patient, and I will try desperately to do that. If they have any questions or concerns, I send them a Dropbox folder just on one item,
Mhm.
and then I get a call like a week later. Oh my God, I had no idea. And I said, what? I said, well, I was going to read the whole thing, and then I opened it up, and there was 80 papers in there. I said, yeah. I said, do you actually read all this stuff? I said, yeah,
Yeah.
I like it.
Yeah. Yeah.
And then they realize, oh, he's not doing witchcraft. This is
Mhm.
evidence-based. It's just all the evidence that the drug companies didn't finance.
Mhm.
And like berberine, golden seal root, it's a miracle drug.
Mhm.
No side effects and gastrointestinal distress like metformin. They always start you off on metformin. Doesn't work very well unless you add on an adjunct, which is a mild insulin sensitizer.
Mhm.
Milk thistle,
Mhm.
Silymarin marinus.
Mhm.
Well, the berberine, golden seal root, can't get into the cell more than 3 to 5%. I was just stupid enough because I got excited and read it too quickly and bought some berberine, and it didn't work. And well, okay, idiot, what are you missing? So I went back. I only had 5 papers. Now I got like 500.
Mhm.
And I saw Silymarin marinus, and the Latin words are always italicized. I went, oh, that's milk thistle. It said you must take 20% of the berberine dose as milk thistle because it'll defeat the absorption barrier, which is P glycoprotein, on every cell, and allow it in. 50% gets in the cell. So they added on the milk thistle, and I'll send you my blood work before and after. It was startling. I couldn't have been happier because I carry some pounds on me, 15 pounds.
Uh-huh.
And now I'm protected from becoming a diabetic with 2 herbs.
Wow. Wow.
And I send a picture of the patient, tell them how much to start with.
Yeah.
Provider already knows I'm doing it. Everybody's cool. And That's not a cure, but it works at least as good as metformin.
Mhm.
It improves your gut health, doesn't screw it up
Mhm.
like metformin,
Mhm.
and it lowers ApoB pretty good,
Yeah.
15, 20%. And when you put all these things together, first I need to know there's an absolute documentable data point that there's a need for each category.
Right.
Then I think, can the thyroid supplementation help here? Would the berberine help here?
Mhm.
Well, this is America. Everybody's insulin resistant, has screwed up lipids.
Mhm.
And whether they know it or not, they probably have one or both, bad blood sugar, prediabetes, diabetes, or hypertension.
Mhm.
And when I see that, then I say, okay, now we need a cystatin C so I can see how much the GFR has deteriorated.
Mhm.
And a lot of them are stage 1 or 2. And I had a nephrologist during the dinner program call me out. Why would you treat stage 2? And everybody in the room kind of looked at him and said, well, so they don't become stage 3?
Yeah, exactly. Or one hit, one viral hit, one major hit, you could take that stage 2 to a stage 3 real
Yeah.
quick. Right. Well, all this makes sense. And again, I'm just so happy to have spent this time with you. And yeah, thanks so much, Steven, for coming on. And any final words?
First of all, I want to thank you from the bottom of my heart. God bless you, because this really
My
helps
pleasure.
things on the home front. And at the very least, it's not me that's important, it's the message.
Mhm. Right.
And I think this is information that needs a wider audience, because after tinkering with this for 22 years, I realized there's way more solutions than most people realize.
Yeah.
And that non-pharmaceuticals aren't witchcraft. And that evidence-based medicine isn't just what the drug companies tell the doctor.
Right.
Maybe they bought lunch and he decided to prescribe something that seemed reasonable. There's almost a fear of using anything that you can't prescribe off a script pad.
Right.
And I understand that. I don't criticize them for it.
Mhm.
But it's the damn healthcare system. And we can thank President Richard Nixon for starting the ball rolling, because if you listen to the Watergate tapes, there's some quotes in there that most people ignored. He had a lobbyist, I think, from the first HMO,
Mhm.
convincing him to take the money, which is the power, and the control away from doctors and give it to health insurance companies. That was the beginning of the end. It gets worse every year.
Mhm.
And I think patients, best advice I can give them, seek out somebody who has a better attitude.
Mhm.
Don't try to find the smartest guy in the world. Find one that's open to new ideas.
Right.
And you might be better off if they're concierge, because you get more time, which will improve your care. And keep your mind open yourself to new ideas, because if you find a doctor like that, maybe he's not familiar with me or this, but he might actually have time, because he doesn't work for an insurance company, to read what I gave the patient to give to him.
Yeah.
And if they do, it'll blow their mind, because the physicians who have a better attitude and have the latitude to express that almost always embrace these new ideas. If it's safe and it works, why not try it?
Right.
If it just happens to be natural and inexpensive, there's no burden there.
Yeah, exactly. Exactly. All right, Steven. Thank you so much. I hope to have you back.
God bless you. I owe you more than I could possibly afford.
You owe me nothing. You owe me nothing.